First, I would like to thank Carlos for this invitation. It is truly an honor for me to be a part of this webinar in which so many amazing surgeons from all around the world have participated. I'm going to talk about the history of joint denervation, general concepts, some specific concerns such as nerve blocks, proprioception, and Charcot. Then I'm going to talk about some important aspects of denervation of the wrist, CMC, and fingers. The history of joint denervation started with Nicholas Rudinger, who made a unique career from apprentice barber to military surgeon and anatomy professor in Munich, Germany. His thesis about the articular nerves of the human body was an incredibly precise anatomical description and the first report about this topic. Later, John Hilton, who was an English surgeon, president of the Royal College of Surgeons, described an anatomical important principle, that is, every nerve crossing a joint innervates it. And this is known as Hilton's law. Interestingly, in our anatomy lab, we analyzed the articular nerves branches going to the IP joint of the thumb because, into our knowledge, there were no reports of the innervation of the joint. But despite some anatomical details that we observed, the outcomes of our study basically follow the principles described by Hilton more than 150 years before. Albrecht Wilhelm was another German surgeon working at the Anatomical Institute in Munich, and he continued the Rudinger work and rediscovered the upper extremity joint innervation and introduced the concept of joint denervation in hand surgery. And the problem that brings us here, regardless of the joint, is that sometimes we must face a situation like this one, where a patient has severe pain, but with almost normal range of motion. And we know that the range of motion is better now than with any current salvage procedure that we could offer. In this situation is where the denervation may play a relevant role. The advantage of denervation is that offers pain relief, preserving motion and function, and also because an unsuccessful neuroectomy doesn't preclude subsequent alternative treatment. Despite a lot of controversies over the years, every day we have more data regarding denervation for hand and wrist. And we can see in this curve the increasing rate of publications indexed in PubMed that also improve the evidence on this topic. The indication for denervation procedures are painful joint osteoarthritis in patients with good mobility that didn't improve with non-operative treatment. And it is contraindicated in patients with joint stiffness because it would be more reasonable to use a different salvage procedure. In patients with previous surgical failures, independent of the cause, and it is also contraindicated in cases with dynamic carpal instability or any other form of joint instability. These cases are, in our opinion, the most important contraindication because an unstable joint needs to be mechanical stabilized or fused, but it doesn't respond to denervation as a standalone procedure. And finally, infection and severe synovitis are all other contraindications to the procedure. One of the main concerns about denervation is the uncertainty of the results. And for this reason, most surgeons use preoperative nerve blocks to predict the success of the surgery. They recommend to use 1% xylocaine and a few minutes later to assess the pain degree, grip strength, and range of motion. But nevertheless, most recent publications refrain from using diagnostic blocks because the analgesic response after the local block in their studies was poorly correlated with the postoperative outcomes. However, other authors found that there was a high correlation between preoperative injection failure and poor outcomes. So in our practice, we are still using preoperative nerve block because it helps us to predict failure, but injections won't predict success, meaning that the test has a negative predictive value. Another major concern about showing denervation is the effect that could have in the hand proprioception. The proprioception is defined as the conscious and unconscious perception of movement, posture, and joint position. If we believe that proprioception is just related with joint capsule innervation, it seems reasonable to believe that joint denervation is going to cause a decreased proprioception. However, it doesn't explain, for example, why a total knee arthroplasty may improve the proprioception of the joint compared to the preoperative status. And this happened because proprioception is a significantly more complex phenomenon involving cutaneous and muscular receptors, and not just the articular nerve branches. But let's analyze the literature about this. Patterson compared 23 PIN neurectomies with 23 healthy patients and found no difference in the proprioception between groups. Guy, in another prospective randomized study, didn't find differences between groups and concluded that the wrist denervation doesn't impair proprioception. In a more recent study, Susan Rain compared 25 complete denervations with 60 healthy patients, and again, no difference in proprioceptive senses of the joint positions, force sense, and reflex time of the wrist were noticed. So the current clinical evidence is not showing a negative effect on wrist proprioception. Every time that we present a lecture about denervation, someone asks about the possibility to develop a Charcot joint. However, until now, there are no reports of Charcot arthropathy related to denervation surgery. And the reason is that to develop a Charcot joint, there also must be an alteration in the blood flow, a loss of the intrinsic matter function, and cutaneous sensibility. And none of these factors are affected in a standard denervation procedure. The first description of wrist denervation was done by Wilhelm. He described a technique using 5 incisions to denervate 10 articular branches to the wrist, and it is called total or complete denervation. Using this technique, the author reported 81% of good and excellent outcomes at 1 year, and 62% of good and excellent outcomes at 10 years of follow-up. Wilhelm originally described these 10 articular branches to the wrist, but now there are reports showing more than 15 branches reaching the joint. So if someone asks if we believe that it is possible to perform a complete wrist denervation, our answer will be no. I personally believe that it is not possible because first, the wrist is highly innervated. Second, because the arteries passing through the joint are usually conserved and are always in company of small nerve branches. And third, because there is a reverse innervation to the joint that is really difficult to dissect. In 1985, Seman, a Czech surgeon, described the partial wrist denervation, sectioning both PIN and AIN. In his technique, the anterior interosseous nerve was sectioned proximal to the pronator quadratus, causing a loss of function of this muscle, which is a secondary stabilizer of the DRUJ. And for this reason, Richard Berger modified this technique by localizing the anterior interosseous nerve and posterior interosseous nerve distal to the pronator quadratus using a dorsal approach. As you can see in this anatomical dissection, the anterior interosseous nerve innervates the pronator quadratus in the proximal third of the muscle and then continues distally to reach the volar capsule, and it is sized approximately 1 millimeter as it crosses the PQ. the posterior interosseous nerve travels over the dorsal aspect of the interosseous membrane and lies radially in the fore-extensor compartment, continuing to the dorsal wrist capsule, passing over the dorsal scaphoid ligament, and it has no motor fibers. And the radial side innervation of the wrist is mostly given by articular branches of the sensory branch of the radial nerve, passing by the radial styloid, and the lateral antebrachial cutaneous nerve. This is a video of the surgical technique for partial wrist denervation. I use a 4-centimeter dorsal incision located 1 finger breadth proximal to the DRHA. Then we incise the forearm fascia over the extensor muscles, and then we find the PIN between the EDC and EIP, just dorsal to the interosseous membrane. We excise 2 centimeters of the nerve, and then we open a window through the interosseous membrane, and the anterior interosseous nerve is found easily and unsectioned in the same way. It is a procedure that usually takes no more than 5 minutes to perform because it is a familiar anatomy for hand surgeons. This is a case example of a 72-year-old patient with slack wrist stage 3 with severe wrist pain and good range of motion, in which I perform a partial wrist denervation through a dorsal approach according to Berger's description, and the patient remained pain-free at 5 years of follow-up, preserving range of motion. But let's see the evidence. This is a systematic review of 12 studies with heterogeneous diagnosis that reported a mean satisfaction rate of 92%, a return to work of 94%, and improved pain scores in 36 to 92% of the cases. This is another case example of a 68-year-old patient hand surgeon with wrist pain in rest and activity that didn't allow him to use the screwdriver without symptoms. Another relevant fact was that he is my father. And on a Friday morning, I found out that he scheduled himself for surgery, and I was supposed to be his surgeon for a wrist denervation. So I went for it. I performed a wrist denervation using Berger's technique. And well, my father is a great surgeon, but a horrible patient. And this was a video of him in the OR 6 days after surgery. And this is obviously not recommendable, but demonstrate a fast recovery after the procedure. So what about the long-term outcomes of denervation? The Mayo Clinic group published a case series of 100 patients with a mean follow-up of 7 years. They observed that 30% of the patients had temporary pain relief but required revision surgery, and 69% had satisfactory outcome with no further treatment. So a high revision rate but satisfactory outcome in 70% of the patients. Fuchsberger published another series of 375 patients with a follow-up of 12 years. They observed that 44% of the patients were pain-free until today, and 56% were temporarily asymptomatic, concluding that denervation is a good alternative even at long-term follow-up, but in some patients, the initial good outcomes were not maintained over time. Some surgeons also perform wrist denervation in association with the salvage procedure, and this paper reported a large series of patients treated with PRC or foreign occlusion, and they analyzed the need to conversion to total wrist arthrodesis. And interestingly, they concluded that PIN neurotomy was associated with a significantly lower rate of conversion to total arthrodesis. Well, now regarding the thumb CMC denervation, there is less literature compared to the wrist, and the publications show variable outcomes. Also, this procedure has a high bar set by the LRTI because independent of the specific surgical technique, Most procedures have a rate of satisfaction over 90%. The CMC joint has a volar innervation coming from the palmar cutaneous and thinner motor branches, as well as dorsal innervation from the lateral antebrachial cutaneous nerve and radial sensory branches. The CMC denervation was originally described by an Argentinian anatomist, Dr. Cosi, who just denervate the dorsal radial branches. But later, Loria reported the outcomes sectioning both the volar and dorsal branches with excellent clinical outcomes. Giesen published a prospective series of 30 patients treated with CMC joint denervation, and pain reduced in all cases with improved grip strength, but 6 of the 30 patients were dissatisfied with the procedure. In a systematic review of 184 thumb denervations with 37 months of follow-up, they observed a satisfactory clinical outcome with a revision rate to LRTI of 5% and minor complication in 11% of the cases. Now going to the PIP joint. There are only a few papers, but with better outcomes compared to the CMC joint. Even more different to the CMC that has a competitor like the LRTI, the most common salvage alternatives for PIP joint, such as arthroplasty or arthrodesis, are far from ideal. A few years ago, we performed an anatomical study analyzing the innervation of the PIP joint, and we observed that the volar innervation is significantly more relevant than the dorsal one. And we also noticed 2 different patterns of nerve branching to the joint. The most common had only 1 articular branch by side, and another pattern with 2 articular branches by collateral nerve. Intraoperatively, sometimes it's difficult to distinguish these small articular branches from other soft tissues. And for this reason, we believe that it is really useful to remember that the articular nerve branches going to the PIP joint are always in contact with the anastomotic transverse arterial branches of the digital arteries that are easier to find in the operative field, especially if you use a tourniquet without exsanguination. The dorsal innervation of the PIP joint is less constant, and it is most notorious in the ulnar digits. This is a video of the surgical technique for PIP denervation. I prefer a volar approach because it is easier to resect the volar branches that are more important than the dorsal ones. We first open the Grayson ligament and dissect the collateral digital nerve. Then we dissect the collateral artery until we find the anastomotic transverse arterial branch, which we said is in contact to the articular nerve branches. And once located, we section or cauterize the articular nerve, and that's it. We complete the procedure by repeating the technique in the ulnar side of the digit. This is a case example of a 61-year-old patient with PIP joint osteoarthritis with severe pain and almost full range of motion that didn't improve with conservative treatment. And this was the outcome 4 years after the denervation with significant pain relief and preserving range of motion. This is another case example of a 46-year-old patient with osteoarthritis of the index, ring, and small finger. In this case, we also performed a denervation that provided temporary pain relief for almost 2 years. But at the 3rd year of follow-up, even after an improvement of the pain scores, the pain had discomfort and decreased the range of motion and required a revision procedure. There are only a few papers analyzing the clinical outcomes of PIP joint denervation. The current literature is reporting satisfactory results with good or excellent outcomes in more than 30% of the patients, but none of the present studies had functional outcomes available, and so we need more and better data to perform an analysis of the current evidence. We believe that shared decision-making is truly relevant nowadays for all procedures, but the perioperative conversation with a clear explanation of the risk and benefit of the procedure is especially important when indicating a joint denervation. Even more, in our opinion, an unrealistic patient expectation is another contraindication for the procedure. So the summary of current publications show that joint denervation, it is a procedure with low morbidity that provides pain relief in 60 to 80% of the patient with significant improvement in grip strength, but has a relatively high rate of secondary procedures at long-term follow-up. And in the summary of our experience, we believe that joint denervation is a good option, and a careful patient selection is a key factor to success. But the results are not always predictable. And finally, this technique doesn't burn bridges, and we always have a plan B in our hands. One special thank to our team in the anatomy department of the University of Buenos Aires, who helped us to perform the studies and dissections that I presented in this lecture. So thank you very much.